We will go to the second part of the benign tumor, pathological variant of benign squamous cell carcinoma. We have classical, this is the most common variant, classic or known as usual. We have varicose. This tumor can be locally invasive, but it does not metastasize. Therefore, it has an excellent prognosis, as you see here. Human papillomavirus is commonly found in the Basiloid and Wort variant, but is uncommon in the Vercas variants and papillary variants. Sarcomatoid, very aggressive and have poor prognosis. Most men die within 1 year of diagnosis of sarcomatoid. Other variants include warty, that's known as condylomatous, papillary, basiloids, adenosquamous. This is a type of benign squamous cell carcinoma cancer-specific mortality and the risk of invasive lymph node metastasis at the initial presentation. Varicose, this is cancer-specific, is very low and have no risk of invasive lymph node metastasis at the initial presentation. Papillary have a low cancer-specific mortality and a low risk of intra-lesional lymph node metastasis or invasive lymph node metastasis. Warty or condylomatous, you have a very low cancer-specific mortality and low risk of ILN at initial presentation. Adenosquamous also have a low cancer-specific and intermediate to high risk of invasive lymph node metastasis at initial presentation. Classic have intermediate, low to intermediate cancer-specific mortality and low to intermediate risk of ILN. Basiloid have intermediate and intermediate cancer-specific mortality and intermediate risk of ILN. Sarcomatoid have a very high cancer-specific mortality and high risk of invasive lymph node metastasis at initial presentation. Treatment of benign squamous cell carcinoma in general. Signs of negative surgical margin. For excision of the primary tumor, a 2 cm tumor-free margin was recommended in the past. Nowadays, 5 mm tumor-free margin is now considered safe. For cases of high grade or high stage, the clinician may consider increasing the size of margin to 8 to 10 mm. So in the past, they use 2 cm tumor-free margin, but nowadays it's 5 mm free margin for it's considered safe, but for high T stage, we will use 8 to 10 mm. Benoctomy. Partial benoctomy is indication for tumor confined to glans, bulbous, distal shaft. If the tumor confined to this area, benign partial benoctomy is advised. Partial benoctomy removes the distal penis, including the glans, distal corpora, and distal urethra. So try to leave 2 to 3 centimeters of the skin length because this permits the patient to maintain some degree of sexual function and void in standing position, upright position. So we must leave 2 to 3 centimeters. The urethral stump is used to create a new meatus at the end of penis. Local recurrence after partial benoctomy is 4%. So the local recurrence is 4% after partial benoctomy. Total benoctomy is indicated for invasive tumor of the proximal shaft of the penis. Invasive tumor of proximal shaft of the penis. Total benoctomy remove all penis distal to the pubic bone. So all penis distal to the pubic bone, that is total penectomy. The urethral stump is diverted to the perineum, perineal ureterostomy, so the patient must void in sitting position. Advanced disease may require more extensive resection, including removal of the scrotum, perineum, and removal of entire corpus cavernosa. This is advanced disease, might require extensive resection, including removing of the scrotum, removing of the perineum, and or entire corpus cavernosa. Stenosis of the new meatus occurring up to 10% of the cases. So 10% of the case up to 10 have stenosis of new meatus. But the stenosis rate can be minimized by spatulating the urethra. Intraoperative frozen section are recommended to achieve negative margin. Glandsectomy. Remove all or some of the glands while leaving the corpora intact. Where partial penectomy remove the distal corporum. So in the glandsectomy, we will leave the corpora. Okay, so the corpora is intact, but in partial we remove the corpora, distal corpora. Partial or complete glandsectomy may be performed based on tumor size and location. Compared to partial penectomy, glandsectomy is more likely to maintain upright voiding and more likely to preserve sexual function. Glandsectomy is typically utilized in men with TA, T1, T2 tumors that are confined to the gland. So if the tumor one of these, TA, T1, T2, and tumor confined to the glands, we will do glandsectomy. Benign sparing surgery. Benign sparing surgery or benign sparing therapy may indicate in men who have any of the following characteristics. If the men have refused or who are unfit for penectomy or glandsectomy, we can give him benign sparing therapy as option. If men who want to preserve sexual function and benign anatomy, also we can give him benign sparing therapy, or men who have carcinoma in situ, okay, or low-grade Ta/T1 tumor. Also benign sparing therapy as option. Benign sparing therapy has a higher local recurrence than partial penectomy, but this therapy appear to achieve comparable cancer-specific survival in appropriately selected patients. So this is a benign sparing, have higher local recurrence. So before benign sparing therapy, biopsy of primary tumor is mandatory to confirm the presence of cancer. Benign sparing therapy include circumcision, that's reserved for lesion confined to the foreskin. This is benign sparing therapy, so includes circumcision, reserved for lesion confined to the foreskin, or witch resection if tension-free closure is not possible, use skin graft. So it is also part of the benign sparing therapy, witch resection. Mohs surgery is also another option of benign sparing surgery, removal of the tumor layer by layer under microscopic control until negative margin are obtained. This is also a benign sparing therapy. This is best utilized for lesion less than 1 centimeter in diameter. So local recurrence rate is 30%. So we mentioned that at the beginning, benign sparing surgery have a high local recurrence. Okay, so the recurrence is very high with this, and we mentioned that the recurrence with Stenosis is a new meatus occurring up to 10%. And we mentioned the local recurrence after partial bunoctomy is 4%. So recurrence after partial bunoctomy is 4%. Stenosis of new meatus, it is 10%. Recurrence with glanectomy is also can occur. Vinyl sparing have a higher vinyl sparing therapy have a higher recurrence, higher local recurrence, including circumcision if carcinoma in foreskin, or ridge resection if tension-free closure is not possible, or Mohs microsurgery removing the tumor if less than 1 centimeter in diameter, and the recurrence is 30% with Mohs. Laser ablation is also, or laser excision, the new demium or new diamond. This is YAG carbon dioxide or KTB laser are typical use. So the local recurrence with laser ablation or laser excision with new diamond is 20%. Glans resurfacing, abrasive removal of the glans epithelium followed by split thickness skin graft or buccal graft to cover the glans. Another vinyl sparing therapy. Topical therapy, 5-fluorouracil or imicamod, used mainly for CIS or TA. Local recurrence is 50%. Local recurrence with laser ablation or laser excision with new medium, it's 20%. And the local recurrence with topical therapy, 5-fluorouracil, is 50%. And this for CIS or TA. Radiation, mainly used for men of stage T1 or T3 tumor if the tumor less than 4 centimeters in greater dimension. Radiation has a higher local recurrence rate than partial or total bunoctomy. Radiation has higher local recurrence rate than partial or total bunoctomy. Recurrence rate after radiation is higher when the cancer in 2 to 4 centimeters in diameters. Radiation is less effective for tumor 2 to 4 centimeters in size. So recurrence rate after radiation is higher when the cancer is 2 to 4 centimeters. That means if radiation is less effective for tumor 2 to 4 centimeters in size. For stage T1 or T2 tumor that's less than 4 centimeters in size, treatment options include brachytherapy alone, external beam radiation alone, external beam radiation with chemotherapy. If T1, T2, this is the option. Brachytherapy alone, external beam radiation, or external beam radiation with chemotherapy. For tumor more than or equal 4 centimeters in size and stage T3, radiation is administered with systemic chemotherapy. Side effects of radiation therapy include meatal or urethral stenosis, that's occurring 20 to 35%, glans necrosis, 10 to 20%, and corporal fibrosis. So stenosis and necrosis and fibrosis. Stenosis occurred in 20 to 35, and necrosis in 10 to 20%, and corporal fibrosis. Circumcision should be performed before radiation therapy to prevent radiation-induced phimosis. Inguinal lymph node dissection, IND, men with non-palpable inguinal lymph node at presentation, 25% will have inguinal lymph node dissection metastasis. Inguinal lymph node dissection when men who have non-palpable node early inguinal lymph node dissection achieve longer survival than delay inguinal lymph node dissection until have recurrence with palpable or nodal that's late in inguinal lymph node dissection. The early inguinal lymph node dissection is recommended in men who have non-palpable inguinal nodes and risk factor for inguinal lymph node metastasis. Primary characteristics that as risk factor for inguinal lymph node metastasis, if stage 1B or greater, if high grade, that's especially when the tumor is more than 50% poorly differentiated, lymphovascular invasion. Men with palpable inguinal lymph node at presentation 50% have adenopathy from inflammation and 50% have adenopathy from metastasis. In the past, these men were given 6 weeks of antibiotic to differentiate inflammatory adenopathy from malignant adenopathy. Node metastases were likely if adenopathy persisted after antibiotics. However, immediate biopsy of the palpable inguinal nodes, preferably by percutaneous needle biopsy, is now favorable diagnostic approach. After treatment of primary cancer, the development of the palpable inguinal lymph nodes during follow-up is usually caused by cancer. For patients unwilling or unable to undergo inguinal lymph node dissection, external beam radiation can be delivered to the inguinal nodes. Inguinal anatomy. The femoral vessels and deep femoral lymph nodes are found in the femoral triangle, which is bounded by laterally by sartorius, superiorly by ilioinguinal inguinal ligament, and medially by adductors longus. Progressing laterally to the medial toward the navels, that structure in the femoral triangle represented by from lateral to medial femoral nerve, femoral artery, femoral vein, empty space, and deep inguinal lymph nodes or callot lymph nodes. The structure in Perineaces are within the femoral sheath. The anterior surface of the femoral triangle is covered by fascia lata. The fascia lata separating from the superficial and deep inguinal lymph nodes. Superficial inguinal lymph nodes, these nodes are superficial to the fascia lata and are divided into the 5 zones. Deep inguinal lymph nodes, that's the deep inguinal lymph nodes, are deep to the fascia lata, are located immediate to the femoral vein in the femoral triangle. The node of callot is the most sevalved node in the deep inguinal nodes regions. The saphenous vein branches from the femoral vein in the deep inguinal regions. It passes anteriorly through the oval window or oval opening in the fascia or fascia lata, the fossa ovalis, and continuing to the superficial inguinal regions. During inguinal lymph node dissection, inguinal skin flap are developed deep to the scarbus fascia. Some surgeons recommend that the lymphatic vessels be ligated rather than cauterized or clipped. Genital tissue handling helps prevent skin necrosis. What's the complication of inguinal lymph node dissection? Lymphocyte wound infection, skin flap necrosis, lower extremity edema. Both operative. Compression, stocking, prophylactic antibiotic may help prevent the complication. So we have a standard template inguinal lymph node dissection or radical inguinal lymph node dissection or full true or true plate inguinal lymph node dissection. Superficial node dissection node in all 5 superficial zones are removed. This is known as a standard template ilioinguinal lymph node or inguinal lymph node dissection or radical inguinal lymph node dissection. So all superficial node dissection in all 5 superficial zones are removed. This is the superomedial, superolateral, inferiolateral area. And as you see, superomedial lateral zone, superolateral, superomedial, and this is the central zone. So this is all 5 superficial inguinal lymph node zone is known as Dazaral zones. Okay, so the sentinel lymph nodes, this is usually from the found in the superior medial zone. So in superior medial zone here, so it is the limit of superficial dissection are superior limit, external oblique fascia or external oblique fascia at the level of spermatic cord. Lateral limit, sagittal plane through the anterior superior iliac spine. Medial plane, sagittal plane through the ipsilateral pubic tubercle. Inferior limit, transfer plane 20 centimeter inferior to the inferior superior, anterior superior, anterior inferior superior, anterior superior spine. So the anterior superior spine. Deep node dissection. The deep inguinal node are removed from the femoral triangle, avoiding the dissection lateral to the femoral artery, which avoid injury to the femoral nerve and profunda femoris artery. During radical inguinal lymph node dissection, saphenous vein is ligated with rise from the femoral vein, where it passes through the fossa ovalis. Then the vein is segmented between the ligatures is removed. A sartorius muscle flap is utilized to cover the femoral vessels after radical lymph node dissection because it reduces the incidence of hemorrhage from the femoral vessels. The origins of sartorius is mobilized from the anterior superior line spine, move medial to cover the femoral vessels, and then suture to ilioinguinal ligament. Modified template inguinal lymph node dissection. Compared to the standard inguinal lymph node dissection, modified consists of the shorter skin incision. The area of superficial dissection is smaller, so the lateral and inferior limit all are different from the standard templates. Preservation of the saphenous vein also, and no sartorius muscle flap to cover the femoral vessels. So we will do short skin incision, and the area of superficial dissection is smaller, that we will use lateral inferior limits. Superficial node dissection node is in the central, superior medial, and medial portion of superior lateral zone. So this is the superficial lymph node dissection, include the central, superficial medial zone, okay, plus medial portion of superior lateral. Okay, so that's, but the node in the inferior zone, which is inferior to the fossa ovalis, are not removed. So we will not remove the inferior zone node. The limit of superficial dissection are lateral limit. We have lateral edge of the femoral artery. Inferior limit fossa ovalis, where the saphenous vein penetrate the fascia lata, so no dissection of the inferior zone. Superior limit and medial limit, same for a standard template inguinal lymph node. Deep node dissection, the deep inguinal node are removed from the femoral triangle, avoiding the dissection lateral to the femoral artery. So some urologists perform superficial modified template, which omit removal of the deep inguinal lymph nodes, because studies have shown that the metastasis to the deep inguinal lymph nodes are unlikely if there is no cancer in the superficial node. However, the regional modified inguinal lymph node dissection described by Catalona in 1988 include removal of the inguinal nodes. Compared to the standard inguinal lymph node, modified inguinal lymph node remove fewer inguinal nodes and has higher false negative rate, 0 versus less than or equal 3.5%. Modified inguinal lymph node dissection has lower complication rate than standard inguinal lymph nodes. The modified inguinal lymph node is utilized in men whose inguinal lymph node are not palpable. When the cancer is found in the inguinal lymph node during modified inguinal lymph node dissection, compared to the standard inguinal lymph node or radical inguinal lymph node dissection. The management of the squamous cell carcinoma in details. So we'll take a look. Just try to revise it as quickly as possible. Pelvic lymph node dissection. Venous lymph node do not drain directly to the pelvic node. Inguinal lymph node metastasis must be present before cancer can reach the pelvic nodes. It appears that the metastases are unlikely to spread from the inguinal lymph node to contralateral pelvic lymph nodes. However, one study suggests that more than 4 inguinal lymph nodes metastases may support performing bilateral pelvic lymph nodes. Consider performing bilateral pelvic lymph nodes in men any of the following characteristics. So more than or equal to inguinal lymph node bilateral node metastasis in the bilateral node of the carot, tumor extension through the capsule of the inguinal lymph nodes, BN3, presence of high-grade tumor in the involved nodes, image suggests suspicious pelvic nodes. If metastases are present in 4 inguinal lymph nodes total along both sides, consider bilateral pelvic inguinal lymph node dissection. Systemic therapy, chemotherapy in men with more than or equal 3 positive lymph nodes found as the inguinal lymph node dissection, BN2 or BN3, adjuvant chemotherapy improves survival. Chemotherapy may be used when primary tumor or inguinal node metastases are unresectable. So, example that T3, T4, or fixed inguinal lymph node CN3. Chemotherapy may shrink the tumor enough to permit excision. Chemotherapy regimens should include cisplatin. Regimen includes paclitaxel, ifosfamides, and cisplatin, so it's known as TIP. Okay, TIP. That's T for taxil, that's paclitaxel, ifosfamides or ifosfamides, cisplatin B. Yeah. So this is preferred even for new adjuvant treatment before node dissection or adjuvant treatment after node dissection, or if the patient have distant metastasis, this is the best regimens. So 5-fluorouracil and cisplatin, bleomycin based regimens no longer recommended because of unacceptable toxicity. So this is the 2 regimens, that's paclitaxel, ifosfamide, and cisplatin, and the second one is 5-fluorouracil and cisplatin. So it must include cisplatin as I mentioned. Okay, so this one, bleomycin-based regimen no longer recommended because unacceptable toxicity. Follow-up and survival for benign CTC. Most recurrence occur within 2 years treatment. Therefore, intensive follow-up is conducted for first 2 years after therapy, with less intensive follow-up thereafter. Follow-up should include patient self-examination of the penis and inguinal nodes, examination by physician including penis and inguinal nodes. After the inguinal lymph node dissection, perform chest imaging, abdominal and pelvic CT or MRI. Prognosis and survival. Men with invasion of the corpus spongiosum have better prognosis than men with invasion of the corpus cavernosum, BT3. So if the patient have invasion to the corpus spongiosum, have better prognosis than patient with invasion to the corpus cavernosum, BT4, BT3. The following tumor characteristics are indicator of poor prognosis. If high primary tumor state, or high tumor grade, or perineural invasion, or basaloid or sarcomatoid histology. More extensive lymph node involvement, the most important determinant of survival in men with benign SCC, is the extent of the lymph node metastasis. Prognosis is significantly worse when the lymph node metastases have any of the following characteristics. So more than 2 inguinal nodes, lymph nodes metastasis, that is the prognosis is significantly worse, or if bilateral inguinal lymph nodes metastasis or pelvic examination or pelvic lymph node metastasis, or extension of the tumor through the capsule of the lymph node. So if extended through the capsule of the lymph node or pelvic lymph node metastasis or bilateral lymph nodes or two inguinal lymph node metastasis, more than two inguinal lymph node metastasis, all this is prognosis is significantly worse when the lymph node in this case. This is the 2017 AJCC American Committee classification for the tumor node stage, and this is the 5-year survival. So in 0, that's 80%, 74 to 100 at range, 5-year survival. In 1, so 81%, 75 to 82%. In 2, 50%, 17 to 18% to 80%. In 2, we have in 2 superficial and in 2 deep inguinal. The superficial is 50% or 17 to 80% as range. In 2 deep inguinal, 29%, 17 to 40% as range. In 3 pelvic, that's less than 10, 0 to 38, 5-year survival. This is the end of the section. Thank you.